This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. We are here with our special Journal Club series that we have been doing at PHM from Pittsburgh. For those of you who are new to the podcast, welcome. And for those of you who are not new, welcome back. We are a continuing medical education podcast, which was started in October of 2016 here at UPMC Children's Hospital, Pittsburgh. I work in the Paul C. Gaffney Division of Pediatric Hospital Medicine. I'm a Med-Peds trained pediatric hospitalist. We've been coming to you with these Journal Club series to discuss different topics on the American Board of Pediatrics content specifications for pediatric hospital medicine, and then some contemporary stuff that has come up that demanded our attention, such as like everybody's favorite virus, COVID. And one of the areas we were trying to figure out how to cover is research, right? For the content specifications, they talk about really understanding research and how to critically evaluate the literature. Now, you can imagine this is going to be difficult, we thought, to cover on an audio-only podcast format. So to pull this off, we've partnered with our colleagues at Dell Children's Medical Center and Dr. Philana Ling Lin, and a group of expert guests, both from the University of Texas at Austin and right here at the University of Pittsburgh, which you're going to meet throughout this series. This is, if you're keeping track, episode 3B. And we have friend of the podcast here, Dr. Jenna Carlson, to help us out. And just so you know, in case you're just joining here, Dr. Jenna Carlson is an assistant professor of human genetics and biostatistics in the School of Public Health at the University of Pittsburgh. She received her PhD in biostats from Pitt in 2017 and completed her postdoctoral training in human genetics in 2018, where she then joined the Pitt Faculty of Public Health, Pitt Public Health. She's an expert in statistical genetics focused on genetic epidemiology studies of complex traits. Dr. Carlson also has a passion for statistics education. She teaches several courses in the Pitt Public Health, as well as our programming workshops through the Health Sciences Library System. And there is no one better to help us with this. And Dr. Carlson, thank you very much for giving up your time to do this.
Well, thanks for having me, Tony. It's great to be back.
All right. Now, Jenna, you know that we need to do our conflict of interest disclosure statements because it is a CME podcast. So I will go first and kick it out to you. So I, disclosing that I was on a Sanofi advisory board for increasing vaccine immunization in immunocompromised patients, should have no bearing on what we're talking about today.
And I have no conflict to disclose.
All right. Now, Jenna, here is the question we have before us. This episode is on types of variables, continuous, ordinal, nominal, and distribution of data, like mean, standard, deviation, skewness. So my broad question to you is, why does this matter to us if we're reading the literature, if we're using this to analyze the literature to see if special studies that have done are any good or not?
Right. Well, I think it all comes down to how we are going to draw conclusions from some kind of study and apply those in practice. So without giving people too much PTSD from their intro stats class that they had a million years ago, the reason that we care about these things is because it directly affects the conclusions. And I think sometimes we gloss over that. There's going to be a difference when you're trying to translate research findings into your practice, into patient care, if data were treated as categories versus a continuous measurement. And I think it also is helpful to understand the data itself and how that relates to the statistical analyses that were employed in the research study. And being cognizant of those can really help you interpret the research and draw a more meaningful conclusion from the study.
All right. So where should we start?
We could start a lot of different places. How would you like
that's right. So for those of you listening, we have been using 3 articles to keep track of everything as we go. So the first is by Courtney et al., bolus versus continuous nasogastric feeds for infants with bronchiolitis. The second is from Thomas et al., the Pediatric Emergency Medicine Collaborative Research Committee, on the HSV study group, CSF reference values for young infants undergoing lumbar puncture. That was in Pediatrics in 2018 of March. And then the third, which we haven't used very much, is Shu S. et al., Effect of Oximetry on Hospitalization and Bronchiolitis, a randomized clinical trial from JAMA of 2014. If you wanted to use one of the papers to help explain what these variables mean, I think that'd be great.
Okay. All right. Well, let's start with the Courtney et al. Paper, the bolus versus continuous nasogastric feed. One of the things that stuck out to me as a statistician was in just looking at their primary findings, they looked at length of stay as their primary outcome. And they wanted to compare length of stay between the two different groups, those that got the bolus and those that got the continuous. And one of the things that they looked at in looking at that variable length of stay, as a statistician, one of the things that immediately pops to my mind is we really need to think about what that distribution looks like. Like, what are all the possible values and which values were more likely than others to appear in this sample? Because it's going to affect the statistical methods that they used and their conclusions. And length of stay is kind of a notoriously skewed variable because, unlike a lot of biometric measurements like height that have a lovely symmetric distribution, bell-shaped, length of stay tends to be really right skewed. So it has a really heavy right tail where a lot of people are really discharged quite quickly. And then there's those that trail on and are stay in the hospital for much longer. And maybe not all, but most of statistical inference is built for bell-shaped symmetric distributions. And so you have to use different statistical techniques if you're working with really skewed data. And this is an example of what they did. Instead of looking at a mean, which is what you might look at if you're comparing something like height or length in a patient, they used the median. And maybe I should take a couple steps back of like these measures that we use and why they are so meaningful is because we're trying to make comparisons. And rather than looking at every single individual observation, we create a summary measure that measures a central tendency. Like, did this group tend to have longer or shorter length of stay? And the mean is probably the most common, followed by the median. But the mean is really influenced by extreme observations. Maybe you call them outliers. Mm-hmm. Whereas the median can be it is more robust against that. It's harder to move a median because it is that mid value. You have to move all of the observations down to the centering ones, rather than just a few extreme observations on the high end or the low end, which will shift the mean quite a bit.
So is what you're saying for this, like for length of stay, mean, which is, I know it as like the average of all the values, can really be affected. So if you had a patient for some reason that stayed 400 days, that's really going to push your mean to the longer end.
Exactly.
But median is more resistant to that. That's literally the center value of all the values you have.
Right. Like in this example you've just given us, if you change one patient's length of stay measure, or if a data entry error changes a patient's length of stay from 40 days to 400 days, you've shifted the mean quite drastically because it's weighting that observation equally to all of the other observations. But the median hasn't changed at all, because it's still the centermost value. So it's really robust against those kind of influential extreme observations that might really skew the findings that you would have from looking at a mean.
So then this goes to this paper, this manuscript's benefit that they used median and not mean. They took that into consideration and were thoughtful about it.
Mm-hmm. Yeah, exactly. Especially in this example, they were really mindful about the distribution of data. And that length of stay measure that does tend to be so skewed. So a more robust finding in looking at that midpoint length of stay, which they found didn't have any evidence of difference between the two groups.
Now, Jenna, if I'm looking at this data, and this is data on length of stay, so it's in hours or days, would I call this continuous, ordinal, or nominal data?
I would think about this as a continuous measure because it has quite a wide range of possible values. And it is something that lends itself to being truly continuous. If we're thinking about it in days, there's the same gap in between observations. So going from 14 to 15 days is the same as going from 16 to 17 days. It's all the spacing is uniform that way. In the data set themselves, they had quite a spread, I think, of length of stay. So it wasn't just a handful of values that they actually observe in length of stay.
Well, that's a great. So now, could you give us examples of and help us understand what ordinal and nominal variables are then?
Sure. So both ordinal and nominal variables are types of categorical data. And I think one of the trickiest parts when thinking about this is that often those are derived from the data that started out as continuous. So you might think about, for example, my favorite example is the number of cups of coffee that you consume per day. And that might start out as a continuous measure that can theoretically take on infinitely many values, depending on what your population you're studying is. But we might collapse those into a few meaningful categories. If we collapse them into these kind of structured, ordered groups, that would be an ordinal variable. So, for example, maybe there's a group that consumes no cups of coffee per day, and then we group 1 and 2 together, and then 3 or more together.
Okay.
We've created 3 ordinal groups because there's an inherent order.
So it'd be like group A, B, and C, that becomes ordinal. Mm-hmm. We're just categorizing these people.
Yeah. Relating that to my initial point of like why this matters is that you should really think about how the data are coded and how they were analyzed, because that might change your conclusions. If we grouped the coffee consumption into those groups that I just mentioned, 0, 1 to 2, or 3 plus, then our conclusions will fall within those categories. So they ought to be clinically meaningful when you create the categories, not just willy-nilly because that's how you wanted to break the data up. So maybe that should be informed by the caffeine content or something like that that's relevant to the disease or the trait that you're studying. Or if it's maybe something else is more meaningful, the behavior that goes along with it or something else. Just think about what you're measuring when you're collapsing the categories and how that tracks with what kind of question you want to answer. Then nominal data is a different type of categorical data, and it's just one where there isn't an inherent order. The most common example is like eye color or something where you can't sort them in it, but oftentimes the data aren't quite that clear cut. So nominal I think of as any kind of category that doesn't have this inherent order, or that doesn't at the distance, you can't think about anything in terms of like distance between the groups. Whereas in ordinal, you can kind of put them in sequential order. Another example might be smoking status or something like that. You can have never smokers, former smokers, current smokers. And while there maybe is some kind of morality or ordering in those, that would more be treated as a nominal category rather than an ordinal.
So if I understand this, let's take height as an example. Mm-hmm. Height can be a continuous variable if you just literally track, 5'1", 5'2", etc. Mm-hmm. But then if I'm doing a study on height, I can make a category of under 6 foot and above 6 foot and call one tall and one short. Mm-hmm. And I am artificially making that up. And then it becomes ordinal data because I'm putting everybody under 6 foot in the short category, everyone over 6 foot in the tall category. But that is not nominal at all. That would be like the eye color you brought up.
Yes, exactly. And then why that matters so much is in your height example, if we are drawing some kind of comparison and we say something affects height, but you've categorized it as being under 6 foot or over 6 foot, it really affects the odds of being over 6 foot or under 6 foot. It doesn't, in your example, people who are 5'11" and 6'1" are in completely different categories than somebody who is 5'2" and 5'4", or 6'3" and 6'5". Those 2 inches, that measurement isn't being used anymore as that continuous underlying measure. So my recommendation as a statistician is if you have a continuous trait, try as hard as you can to work within a statistical framework that can treat it as continuous. And if you get in a situation where you need to dichotomize it, to break it up into categories, then, use clinical information to inform that. So I work a lot on cardiovascular disease. A common example is blood pressure. If we're really interested in things that are moving the needle on blood pressure, we can treat that as a continuous measurement. If I'm looking at things that are going to affect diagnoses, then I can use clinical cut points to diagnose hypertension as an outcome variable. But I am losing information. If something is moving, if there's something that has a pretty small effect that's moving somebody from 110 to 120, that might be important, but I might be missing that if I'm using a 130 or 140 cutoff.
Oh, okay. So that's the clinical relevance you're talking about. You may lose some of that fine detail when you go from continuous to ordinal.
Right. Exactly.
Were there any examples of nominal data in the papers we have?
Oh, here's an example of something that is nominal in the presentation here. Of a lot of them are two categories, so it's a little bit challenging to make the distinction between nominal and ordinal. But just to give you some examples, there are the presentation of the patient, whether they were a primary admission or a retrieval. Medical history is a great one. So these are a bunch of different little categories that were like yes, no. Did they have previous bronchiolitis? Are there smokers at home? Were they premature? Do they have eczema? Each one of those is actually probably a separate variable. I know we like to collapse them under all like one broad thing, but because somebody could have eczema and have smokers at home, it's not a medical history isn't by itself a variable for statistical purposes. Each one of those would be broken down into a yes, no category. Then the other one would be the PCR results. So they did a respiratory virus PCR, and there were 4 possibilities listed here. 1 is that it's not done. 2 is that it's RSV positive. 3 is RSV negative. And then the 4th option was 2 viruses detected. So that would be a single variable because each person can only fall into one of those categories. And it's nominal because there isn't some kind of inherent order based on a continuous measure.
So that's one of the points I wanted to make sure we cover. So in my tall short example, the reason the 2 categories, tall and short, are ordinal and not nominal is because there's a continuous variable we can measure to put them in that category. But in your examples in the paper, if somebody has eczema or does not have eczema, that is not a continuous variable. That's a yes or no question, and that's why it's nominal. Did I say that correctly?
Yes, exactly. And it's tricky because sometimes there are some variables that people automatically think of that they should be ordinal at least, if not continuous. So like in that smoking example, it's really going to depend on where the data was abstracted from. If it's from a chart review, look at the question that was asked to enter the data. I find this a lot with smoking status. There's a lot of different ways you can measure it. You can ask how many cigarettes do you smoke per day? And then they give you a number. And then if you create categories from that number, then it can be an ordinal variable. But if you ask them to like fill out, never smoker, current smoker, former smoker, that's not based on that underlying continuous measurement, even though there might be something happening there. But if you're not collecting that continuous measure, you can't turn it into an ordinal variable.
That is so helpful. I feel like I understand that now. Should we talk about distribution of data like mean, standard deviation, and skewness?
Sure. Yeah, I think there's a couple of important points when looking at research and some things I just want to tune everyone into. So the distribution matters because statistical tests all have assumptions about what that distribution should look like, and everything, regardless of whether it says this in conclusions or not, all of the results are completely dependent on how well the data fit the statistical model. And so most stats were developed for normal distributions, that lovely bell-shaped symmetric curve, like what we see when we measure height. But there are some that are for non-normally distributed data. So the distribution matters. But more above and beyond that, there are a couple key measures that we use in these statistical things. One of them we've already talked about is a measure of the center of the distribution. That's your mean or your median. And then the second one is a measure of the spread of the distribution. So if you have, let's say, for example, we're comparing 2 continuous measures, like the length of stay between the 2 groups. Okay. There's the bolus and the continuous NG feeds. What we're really wanting to do is to compare those centers, those medians. Are the medians really similar or are they really different? But what we need in order to do that well is a metric of, well, how much variation was there in the data itself? How far apart are the medians relative to the whole spread of the data? And that's where we bring in standard deviation or interquartile range. Kind of the standard deviation is a buddy of the mean, and the interquartile range or IQR is a buddy of the median. So they measure kind of that signal to noise ratio is how I think about it, like this, the distance between the means relative to the standard deviations, or the distance between the medians relative to the IQR is one way to think about it.
So when you're asking that, is what you're saying, and correct me if I'm wrong, what you're looking for is to make sure the median, when you go 2 standard deviations from the median, you're covering roughly 99 or 95% of the population. Is that what you're looking for? Or if your curve is shifted so far one way to the other that doesn't happen?
A couple different things happening under that. So one of the things is that we typically don't use the median with the standard deviation. The standard deviation depends on the mean. It's calculated as almost the average distance away from the mean. So it's really dependent on the mean. But you're right that in a normal distribution, we see most of the data falls within the plus or minus 2 standard deviations. So we are looking for things that are far apart. The means are far apart relative to the standard deviation. When we're comparing 2 distributions, it's like if you can imagine 2 curves that if you can pull them apart, the kind of the width of the curve is going to be really important to see whether that distance is statistically different from each other or not.
Okay. So you're looking for the width of the kind of the bell-shaped curves that we're used to when you're using median, and you want to be certain that the curves are, if you can hear in the background, they're mowing our lawn, so I am sorry if you're hearing that right now. And I have the headphones in to drown that out. Okay. Did I understand that correctly, Jenna? Because I feel like if I'm a new listener hearing this for one of the first times since med school, I don't know if I understand that fully.
Sure. Well, let me try a different example then.
Okay.
So the reason we have, let me come up with an example for length of stay, just for example. And let's pretend for a second that a mean is a good measure so that we're looking at just the average value, which I know we said in the beginning it wasn't, but let's just hang with me for a second.
Okay.
So let's say we are looking at this patient population with an average length of stay of 14 days. If we see a different population and they have an average length of stay of 16 days, how do we decide if that is a meaningful difference between those 2 groups? You know, if one treatment is having 2 days shorter, one answer is just like your clinical intuition, which is where I can't help at all. My medical knowledge comes from television shows, but and some epidemiology coursework, but nothing really that you should listen to me for my clinical opinion. But so maybe as a clinician, that's just, yes, 100% I'm willing to try something that's different if it's going to get me 2 more days or 2 fewer days in the hospital. But statistically, how we would think about that is like, okay, well, let's look at the data that underlies that. If the average was 14 days or 16 days, what does the spread, what's the range of that data look like? And that's where we use something like the standard deviation. So if the standard deviation in both groups was a single day or a half a day, you can imagine really tightly drawn curves that are centered at those numbers, 14 days and 16 days. So the curve, there's a lot of space, a lot of white space in between them if you're plotting the data. Whereas, okay, then now let's pretend the standard deviation was much higher. It was like 2 days in either of the studies. And the curves are completely overlapping. They almost look like a Venn diagram where there's lots of overlap happening between them. And so statistically, we're not going to find difference between those groups. And maybe there isn't any underlying differences between the 2 treatments. It just so happened that we saw different average lengths of stay. So together, a measure of center, like a mean, and a measure of spread, like standard deviation, can help us make conclusions about differences that we see between treatment groups and research.
Okay. So looking at the distribution of the data, looking to see if the data is similar enough or if the distributions are similar enough to be able to compare the 2 groups.
Mm-hmm.
Okay. And then how does median get involved in that if we're using that?
Yeah. So the example I've just done is with mean and standard deviation. A median, like we talked about in the very beginning, is a different measure of center because it's more robust to outliers. So if you have a really skewed distribution, you might use a statistical technique that will use the median rather than the mean because it's not so influenced by those tail observations. Maybe you have a couple really sick kids who have stayed in the hospital for a really long time, but you don't want that to influence like the broad changes that you're seeing in everyone. So you might use a median instead. And a median's just a really similar measure of center for a symmetric distribution, but in those skewed distributions just gives you a little bit more of a statistically conservative measure of the center that's less wiggly when you had stuff in the tails.
Okay.
And then there are some different statistical techniques. If you've heard of non-parametric statistics or robust statistics, anything like that, a lot of times they're using the median rather than the mean to measure the center.
And the wiggliness we've been talking about and how the curves can be different, can we call that skewness?
So skewness has to do more of like where the data are falling relative to kind of the measure of center. If you have a distribution that, especially things that where we're counting a lot, like it starts at 0 and then goes on for any number of things like length of stay, number of days in the hospital, those tend to be really skewed because it's non-symmetrical. So if you fold it in half, it doesn't really work. It doesn't line up perfectly. And it has a heavy tail. So what that means is if you're looking at like a little chart where the number of days are along the x-axis, then it will keep going on for a little bit. There will be data out in that as you keep going on with higher lengths of stay. There will be more data out there. So skewness has to do with that shape of the distribution.
So can I ask a silly example? Let's say I wanted to measure height again, going back to my height question, and I went to the NCAA men's or women's basketball finals or basketball tournament, and I measured the height of the players only. Would I get a skewed distribution because I'm only almost exclusively, with very few examples, measuring very tall people?
Probably, yeah. If you imagine, especially if there was some kind of minimum height requirement to participate. Well, I don't think that's actually true. I think empirically it might happen that way, that there is a bias against shorter players. But yeah, you might get a more skewed distribution because you are out kind of in the tail of quote unquote, I don't like the word normal, but like average human variation in height.
Yeah. Okay. So we have covered the types of variables, continuous, ordinal, nominal, and the distribution of data, mean, standard deviation, and skewness, which is what we wanted to cover. Is there anything we didn't talk about that you think we should to help with this topic?
No, I think that just about covers it, and I don't want to inflict any statistical trauma on anyone else, so we'll save some of the more nuanced details for a later podcast.
For a later podcast, yes. All right, that sounds great. Well, I mean, this was great, Jen. This is a hard topic, and we needed an expert like you to help walk us through this. It's extremely also, I think, harder to do in an audio-only format where we're trying to have these discussions and hammer it out.
Definitely. I'd like to just draw you some pictures on my whiteboard back here. Yeah.
And for those listening, I'm looking at the whiteboard. There's lots of good pictures on there already. So I think we'll find out from our viewers how they think we did. But I think this was a great show. So thank you very much for joining us. I really appreciate it.
Thanks so much for having me. This was fun.
We'll see you next time.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guest for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!